Hello everyone, thanks for having me. It's great to be here to talk about Housing First. So I'm sure you've heard a bit about it, but I'm going to give a brief introduction of how it's working in England and to discuss how the outcomes for Housing First are relevant across a wide range of areas, including mental health, physical health, and substance misuse. So it's an alternative intervention which has been shown to be very successful in ending homelessness amongst people with multiple and complex needs that other services have been unable to support. So, great. At Homeless Link, so we're the national membership body for services working to support single homeless people. We have about 750 member organisations across the country, and we run the Housing First England project, which is aiming to ensure Housing First is an available option for everybody that needs it, partly through improving the evidence base within an English context. So our research programme is designed to learn directly from the services delivering Housing First, and we've carried out or commissioned a number of different research projects, including surveys and interviews with existing services to create a picture of what's currently being provided. We've done commissioned work out to York University, where they've analysed local authority and service cost data to analyse the cost effectiveness of Housing First in an English context, and some in-depth timeline interviews with residents. So today I'm going to draw on some key findings from across a few of these different research projects to share with you the role of Housing First, not only in ending homelessness, but in improving health. So the original Housing First model was actually called Pathways to Housing, and it was developed by Dr. Sam Pembers in New York in the 1990s, and the early approaches were heavily influenced by the mental health resettlement and support service models, specifically ACT and ICM models, which I'll come on to talk to in a bit. And support was delivered, the idea was support was delivered to formerly homeless people with high and complex support and treatment needs, including a diagnosis of severe mental illness in their own home. So in the UK, there's a lot of philosophical consistency with the original model, but how it's been operationalized is slightly different. So in the UK, services generally support people with reoccurrent or repeated experiences of homelessness who other services have been unable to support. So a diagnosis of mental illness is not necessarily a condition to accessing most services. It's an international movement. It's been widely adopted across the US and in Canada. It's central to the national homelessness strategies in some countries, for example, Finland, which is the only country in Europe which has seen a reduction in the number of homeless people in recent years. It's growing in popularity across Europe and the UK, and in 2017, the government committed £28 million to support 3 pilots. So what is Housing First? So homelessness services are designed and commissioned in different ways, but generally they do follow a set of broad patterns. As part of the traditional approach adopted by many services, people will often pass through a series of accommodation or treatment services and will have to meet certain conditions, so remain abstinent from drug or alcohol, or demonstrate housing readiness before they can take on an independent tenancy. Now, what happens with some people with multiple and complex needs? They're unable to meet these different conditions and therefore end up getting stuck in these different stages or disengaging from the housing pathway altogether. Housing First stands in direct contrast to this approach. It immediately provides permanent housing to homeless people without any conditions attached to recovery. The only condition attached is a willingness to try and maintain a tenancy. Housing First is based on the principle that housing is a human right, and is based both on housing and the provision of intensive support. So it's not a panacea, it's not the solution to all homelessness, it's for a very particular group of people, people with the most complex needs. Due to the level and severity of people's needs, Housing First teams, the support teams, have much smaller caseloads than what's usually the case in the homelessness sector. Findings from a survey that we carried out last year indicates that Housing First services in England are specifically targeting a group that international evidence has shown Housing First have the most success with. So it's people with long-term experiences of homelessness, high rates of mental health problems and substance misuse, as well as other support needs. All Housing First services in England will operate according to 7 key principles. Housing is prioritised, services commit to long-term offers of support that don't have an end date. Flexible support means that the team links with services across different sectors to help meet the full range of an individual's needs. Person-centered planning means that people help to lead and shape the support that they receive. And in individuals, housing is not conditional on them accessing support, which is quite different to the approach that is usually adopted within this country. So Housing First is based fundamentally on this principle of unconditional positive regard, and that the idea that there's always a possibility for people to make improvements in their health and their well-being. Staff will aim to support individuals to undertake practices to reduce harm and promote recovery in the areas of substance misuse, physical health, and general well-being. How is support organised? So it's generally organised in one of three ways. So in the assertive community treatment model, support is usually provided via multidisciplinary teams. This is not very common in this country. In our work, we've only identified one service which uses this model of support, and it's where the service has secured 2 secondments into the service, a local mental health nurse and a substance misuse worker. Due to the range of public services and the cost associated with this model, the range of public services that are available in England, so if you compare to America, where this is more commonly used. So this approach, not so common. ICM, much more common. This is the approach services will generally use. It looks a little bit like an intensive floating support service. So teams will act as navigators. So usually it's one support worker will build a trusting relationship with a resident and help them to access existing mainstream services. And we have identified one other model of support currently in use in this country. In this approach, staff operate within established networks of organisations that focus on multiple disadvantage. So, for example, the making every adult matter areas. Housing First has been shown to be consistently successful in ending homelessness in around 8 out of every 10 cases. So this has been repeated in countries that are profoundly different from each other. And the evidence is drawn from a number of randomized control trials carried out mainly in the US and in Canada. The evidence has also shown improvement, or at least stabilization, in terms of substance misuse, health, and social inclusion. Looking at some of the health outcomes in a little bit more detail, there's been randomized control trials that find positive results in the control of HIV, to some extent across standard physical health measures, a reduction in time spent in hospitals. There's quite a few different studies showing reductions in frequency of hospital stays, and there's been a review of research and findings from a project in Canada that has demonstrated benefits for people with severe mental illness, including improved community functioning and quality of life. In an English context, there's been a review carried out by York University of 9 Housing First services in 2015, where 63% of residents self-reported improvements in physical health, 66 reported gains in improvements in the mental health, and in analysis of service in Stoke-on-Trent, there was reduction in A&E attendances and hospital inpatient nights. Now, it is an important point to make that whilst progress to housing sustainment can be steady and rapid, Housing First is working to support some of the most complex and vulnerable people in our society. So the journey towards recovery won't always follow a linear trajectory. So there will be slips or bumps on the roads to recovery. And Housing First is designed to recognise and respond to that by the provision of ongoing intensive support. Last year, we commissioned Nicholas Pleece and Joanne Brethren at York University to explore the cost-effectiveness of Housing First in England by drawing on the results from surveys with Housing First services, local authorities, and people using Housing First. And I want to talk just very briefly about the idea of cost offsets. So the idea of cost offsets is captured within this the idea of the $1 million Murray problem in America. And what this refers to is a situation where an individual with multiple and complex needs can't get access to the right sort of support to help them exit homelessness. So instead they become, quote unquote, frequent flyers. So they make repeated and inappropriate use of homelessness services and expensive public services such as A&E. And in the case of Murray, a real individual who died on the streets in America, experiencing repeated and extensive contact with the US criminal justice system. So emerging evidence from the UK and from Canada and Finland indicates that housing first is most likely to be effective and generate the highest cost savings when used to help people with the highest support needs who are heavy users of homelessness services and other health services. So one area of savings for the NHS is in regards to emergency services. So housing first support workers should enable people to access the NHS through common routes, so through GP appointments, through outpatients attendance, and ensuring that they are registered with and make use of primary care services. Housing First should support people to have better contact with community health nurses, with addiction services, rather than people only receiving treatment or care when crises arise. So if somebody has multiple and complex needs who is repeatedly homelessness, repeatedly presents at A&E, yes, there's a cost each time that individual presents. So Housing First might help to reduce costs, won't necessarily help the NHS to spend less on A&E because too many other people use A&E. So that's the same could be said for any public service that's operating at scale. But there is an advantage for a service such as A&E for supporting people who have repeated and sustained contact with these services. It will at least ease some of the pressure on staff. So the $1 million Murray argument in the States is just as relevant here. Generalizing about NHS costs is of course quite difficult. It depends what people are being treated for, what the cost of the treatment is, if they can stay in hospital, if they can attend as an outpatient. But broadly speaking, an A&E visit will cost more than a GP appointment. So avoiding emergency service use will reduce costs. So receiving care and treatment means that crises are less likely to arise. So this slide shows findings from 29 people using housing first services in England, which explored changes in the service use since accessing one of the participating 15 housing first services. And the questionnaire asked people which services they had used in the last 90 days and how that might have compared to the pattern of service use in the 90 days before they accessed Housing First. So the findings do show there's some changes in service use, lower levels of A&E and hospital admissions associated with severe mental illness. And yes, this is a small group of people, and the changes being reported were sometimes marginal, so a few less visits to the A&E here, a few more appointments with the GP there. But as shown in this next table, even these quite small shifts in service use produce reductions in spending that quickly start to add up. Am I in time? So I'm just going to skip forward very quickly because I just want to show you this map from another study that we did. This was a qualitative study that we did with existing Housing First residents, where we asked them to draw a map of their experiences of receiving support from Housing First services. So it just gives you an idea of how this support works in practice and how sort of ICM models of support can help people to access and engage with other services. So what people we included on the journey maps wasn't completely up to them. We said, well, you know, where were you before you started accessing Housing First, and where are you now? What's been happening along the way? And most people spoke at length about how the support worker helped them to access other services and attended appointments. So it didn't follow a clear pattern. It happened different times in different ways for different people, but its prominence within the timeline suggests it's an aspect of Housing First that people particularly value. So you see after 1 month, this is one individual who'd been working with Housing First for about 1.5 years, and she's talking about her engagement with the support worker and how after 1 month, the support worker helped her to make a doctor's appointment, and after about 10 months making an appointment for SARC and you know, getting her and being able to access the dentist. And a large role of the support workers will be helping people to break down the barriers that they experience, whether that's having the confidence to actually to go to the appointment, to helping them to go with them to the appointments. And so what this map also shows that in some situations, costs may increase when people have not been accessing services, come into contact with the treatment and support services they need. But earlier research has shown that more effective contact with other services is a key outcome achieved by Housing First. I'm just going to skip forward to the conclusion. So, in conclusion, we would argue at Homeless Link that Housing First should be recognised as a health and wellbeing intervention as well as a housing service, because the outcomes of Housing First are relevant across a range of areas, including health. With the importance of stable housing to areas such as health being increasingly recognised, it may be desirable to seek contribution from a wider range of funders. And Housing First is designed to connect up to other services. Its effectiveness will depend on incorporating support and services for addiction, mental and physical health. And I just want to say as a final point, whilst arguments relating to cost offsets and cost savings are important, the ways that Housing First can positively change the lives of people who would otherwise be caught in sustained and long-term repeat homelessness should really be the real measure of its value. Thank you very much.
Mayday Trust. It's about the cost effectiveness really, and you talked about different contributions from funders. What's your experience of that actually really happening, and how realistically can we get different commissioners with different pots of money to contribute? Because we've had conversations with organisations with health responsibilities saying they won't pay for housing things. I'm sure that's common in lots of places. So how do you see that panning out? Particularly given in the main hall there was a suggestion this should be mainstreamed rather than a very small number of people.
Okay, another question on funding. Anyone else? Hi, Rachel Brennan. I'm Service Manager of Urban Village Medical Practice in Manchester. I think the health outcomes are really interesting, but I guess what can we do to support commissioners? Because I think a lot of the Housing First properties, particularly in Manchester, aren't near to the practices that traditionally support homeless patients, and how do we support mainstream GP practices to help people with complex health needs address their health issues?
Great, thanks. So I think the first point you made about some of the pilots being shut down, not because they weren't shown to be successful, but quite simply because they ran out of money. And one of the challenges that we experience within Housing First is this tension between a long-term offer of support without a fixed end date and then fixed-term funding, which has very much been built upon or reflects sort of the hostel system and funding cycles that fund sort of existing supported housing arrangements. So at Housing First, yes, we're certainly aware that that's an issue, and we're doing a lot of work to try to support services to improve the evidence base in order to we're working together with the pilots. We're doing fidelity assessments at the pilots, and we're doing sort of a lot of work with government to try to raise awareness of the approach. And it is quite tricky as well, helping sort of commissioners and funders sort of understand that how you might fund, how you might understand success, and how you might understand outcomes is completely different. And that's why whilst we have such a strong evidence base, it is challenging because a lot of it is winning over hearts and minds. It is radical. It's completely different. So I think that's also partly why it's a bit of a slow process, and hopefully we'll see a lot more longevity with the pilots than we did the initial projects, when there was also a lot less support and a lot less political backing for the approach than what there is now. In terms of the second question, which is in regards to funding from a range of securing funding from different sort of sectors or different, we have done some research on this topic. And whilst the main source of funding is usually from housing support budget, there is some evidence of sort of funding being contributed from sort of adult social care teams, CCGs, and better care funding. Sometimes usually on a smaller scale, and it's often pooled budgets. So for a service or for particular individuals. And yes, there's all sorts of challenges that we face in order to sort of attract a wider pool of funders, budget pressures, of course, and funding streams, and often government departments working in silos. But actually, what Housing First is a service that spans lots of different sectors. So I think we have a lot of awareness raising around that. I think the health we have a lot of awareness raising to do within the health sector. We also have, I think, in terms of the evidence base, yes, whilst it's very strong and the international evidence is very strong, I think there's improvements that can be made within England, and especially to make it attractive to health funders, because whilst the standard of evidence is very, very high for a homelessness service for within the health sector, of course, the burden of proof can be more exacting. So I think we need to be attentive of that within the homelessness sector and within the evaluation of the pilots and within the as we continue to build the evidence base, we need to ensure that it's meeting those very high standards of proof that's necessary to attract sort of health funders. And in terms of the third question, what can we do to support mainstream GP practices to better support people with complex needs? I'm sure there's a whole host of different sort of activities and responses that we could be doing. In terms of Housing First, the way that the ICM support team should work is they should be connecting with the different services in an area that the Housing First resident is likely to access and engage with. So that relationship building and going out into the community and speaking to people and generating awareness about the service and and trying to break down those barriers should be an inherent part of Housing First. Housing First services won't be successful unless that occurs. So I think that's, on a local level, that's one way in which that could happen. Yeah.
Thank you very much for presenting that. I just wanted to sort of understand, how can voluntary services that are working with, very entrenched, complex individuals support you locally to kind of really push this forward? Because I feel that we've been kind of trialing this for way too long.
Yeah.
And it just needs to kind of get out. I was just wondering how local voluntary services could support you on the ground to kind of push this forward.
Certainly. I mean, I think we're seeing that in areas like where the meme approach is in place of fulfilling lives, and I think those are examples of areas where other voluntary services are kind of more involved with the approach, more aware, and I think in terms of really working together in order to understand and reduce the barriers that people face, that residents face to accessing other services, and helping other organisations to understand, well, what are those barriers and how can they be reduced? Because the actual support worker can only do so much. They're acting as a navigator, so they're trying to help people, access these different services. So without them all working together, then it's not going to be successful. So I think when we go out there and we're talking about Housing First, we need to be talking to a wide range of different sort of community partners and voluntary organisations, not just those that will be delivering Housing First, but those with whom a Housing First resident might come into contact with, and ensuring that they're aware of the approach and they're behind it, and maybe exploring the adoption of the meme approach if it's not in existence in an area could be a key way of supporting the Housing First model as well.